Actually, this patient, he has come with a 70-year-old man who has presented with difficulty in treating hypertension, and he had long-standing hypertension which was well controlled over many years, but it recently was found to have blood pressure of 190 by 110, and it is resistant to additional treatment. He was generally asymptomatic and complied with medication. Investigations showed normal urine and urine examination as well as electrolytes. Which of the following is the most likely cause? The causes choices are pheochromocytoma, polycystic kidney disease, chronic pyelonephritis, renovascular disease, and Cone syndrome or primary hyperaldosteronism. So these are the choices. So what is the problem in this case? This case is a hypertension which is presented with very high BP. So when you see somebody with hypertension, what you should do? You should see whether it is essential hypertension or is it secondary hypertension. Secondary hypertension means essential hypertension means the usual essential hypertension, whereas secondary hypertension means so it can be essential hypertension versus secondary. So when will you suspect a secondary hypertension? One is if hypertension is detected before the age of 25 years or after the age of 55 years. Then you have to think of secondary hypertension. Then if the patient is having evidence of end organ damage, at presentation, then if the patient is having accelerated hypertension at presentation, and the previous one, end organ damage, means patient may be having evidence of what is it called, renal failure, retinopathy, LVH, all these things at presentation itself. Then patient may present with accelerated hypertension at presentation itself. Then if the patient is having uncontrolled hypertension which is difficult to treat or which is remaining uncontrolled despite 3 antihypertensive medications, of which one should be a diuretic. The patient is having uncontrolled hypertension which is difficult to treat with 3 drugs, of which one should be a diuretic. Then the other thing is this, what is it called, the patient who is having stable hypertension develops uncontrolled hypertension. So stable hypertension becoming uncontrolled. These are the things when we think of the possibility of secondary hypertension. Then then one more thing I forgot, that is flash pulmonary edema. If the patient presents with flash pulmonary edema, flash pulmonary edema means patient with normal LV function but they present with pulmonary edema. Usually maybe the first time, if they present with the pulmonary edema for the first time. So it is called flash pulmonary edema. These are the things when we have to think of secondary hypertension. Then we can evaluate the patient, and some investigations also will give you a clue regarding secondary hypertension. Secondary hypertension, the other causes are, one is, most common cause of secondary hypertension is renal parenchymal disease. That is the most common disease, most common cause of secondary hypertension. So how will you make a diagnosis of this one? So in such cases, they may be having some urinary findings, especially proteinuria, urinary abnormalities. Maybe proteinuria, hematuria, etc. That means patient is having some renal parenchymal disease, especially glomerular disease. Then it can also be, what are the other causes of the other causes include, one is renal artery stenosis. In renal artery stenosis or renovascular hypertension, what will happen? There is decreased blood supply to the blood flow to the kidney. So what will happen when there is decreased blood flow or hypoperfusion to the kidney? It will be sensed by the juxtaglomerular apparatus, which will produce renin. Renin will, what will happen? Renin will secrete, will help to renin. Renin will stimulate angiotensin. Angiotensin, actually it is produced as angiotensinogen, then angiotensinogen, then it is converted to
unknown caller.
Angiotensinogen, which is converted to angiotensin 1, which is converted to angiotensin 2 by ACE, angiotensin converting enzyme. So it will convert angiotensin 1 to angiotensin 2. This angiotensin 2 will stimulate secretion of aldosterone. Aldosterone, which is a mineralocorticoid. So it will stimulate aldosterone secretion. So that is called renin RAS. Renin RAS. RAS means renin will stimulate angiotensin aldosterone. Renin, angiotensin, aldosterone. So what are the effects of mineralocorticoids? How it will increase the blood pressure? This mineralocorticoids or aldosterone. A typical one is mineralocorticoids. Typical one is aldosterone. What it does is, it will increase the absorption of sodium. At the same time, it increases the absorption of sodium, but at the same time, in the distal convoluted tubule, in that portion of the tubules, actually it mineralocorticoids that will increase the excretion of potassium and H plus. H plus and potassium secretion is increased. It is increased secretion of these two things from the body, from the kidney or kidney tubules. So what will happen when H plus is gone? It will result in, when H plus is gone means there is excess of, when acid is gone, bicarbonate increases. So HCO3 increase is called alkalosis, that is metabolic alkalosis. Then when there is loss of potassium, that will result in hypokalemia. So in a patient with mineralocorticoid excess, increased mineralocorticoid, that is aldosterone, it will result in loss of H plus and potassium by the kidney, and this will result in hypokalemia. So when there is loss of potassium, it will cause hypokalemia, and also it will result in loss of H plus will result in metabolic alkalosis. So in ABG, what you get is, if you do an ABG for these patients with mineralocorticoid excess, they will be having metabolic alkalosis, then they will be having hypokalemia. So when will you have increased aldosterone, mineralocorticoid? It can occur in various situations. The first one I have already mentioned, that is when there is decreased blood flow or hypoperfusion to the kidney, it will increase the renin, then which increases angiotensin and aldosterone. So RAS system, renin, angiotensin, aldosterone system, that is one method. So in renal artery stenosis, you will get activation of renin angiotensin system because of the hypoperfusion, and it will result in increase in aldosterone. Aldosterone is a mineralocorticoid. It increases loss of H plus and potassium from the tubules. So what will happen? It will result in metabolic alkalosis and hypokalemia. So that is one thing. Then mineralocorticoid secretion can increase on its by mineralocorticoid secreting tumors. So mineralocorticoid secreting tumors can occur in the adrenal. So when there are these things, what is it called, tumors which secrete mineralocorticoid or aldosterone secreting tumors, so there will be excess of aldosterone. So it is called hyperaldosteronism. So whenever there is hyperaldosteronism, that is called Cone syndrome. Cone's syndrome is mineralocorticoid excess. So that is Cone syndrome. So in Cone syndrome, in renovascular disease, you will get hypokalemia with metabolic alkalosis. So keep all these things in mind when you try to answer this question. So what are the choices? This patient is having some difficulty in controlling hypertension. So difficulty in treating hypertension. So in a 70-year-old male, that I already mentioned, in hypertension in a patient who is less than 25 years or more than 55 years. So it is a 70-year-old man, and though he is having long-standing hypertension, but it is become uncontrolled. Many years it was under control, but recently it is uncontrolled. So means, so somebody with hypertension which has recently become uncontrolled, that also we have to think of secondary hypertension. Then at presentation itself, his BP is 190/110. When the patient presents with such high blood pressure, you have to think of secondary hypertension. So secondary hypertension, I have already mentioned, commonly can be due to renal parenchymal disease, for which, but in renal parenchymal disease, urine will be showing some abnormality usually, or the patient may be having some renal dysfunction also, may be there, need not be there, but urine will be showing abnormalities. So it is not a renal parenchymal disease. Then electrolytes also, they have mentioned it is normal. So urine is not showing any findings. So it is, what are the possibilities in this case, in this one? So since the urine is totally normal and there is no mention of hypokalemia, and first I will talk to you about urine is normal. So it can be pheochromocytoma, can be polycystic kidney, then it can be renovascular disease, or it can be Cone syndrome. In all these things, urine need not be abnormal. But in chronic pyelonephritis, urine may be showing pus cells. So it can be chronic pyelonephritis is out now. So it is not chronic pyelonephritis. Then the other choices are there. Then patient is having, it is mentioned electrolytes are normal. So it is, what are the cases where you will get hypokalemia and all those things? So it is, Cone syndrome is unlikely. So patients with Cone syndrome, they present with metabolic alkalosis and hypokalemia. So it is unlikely. Then the next one is, he is having long-standing hypertension. So it can be polycystic kidney disease, that I agree, but recently it has become uncontrolled. So it may be, he may be having some disease, even polycystic kidney disease he may be having, but the reason for recent uncontrolled hypertension is not that. So it is, that also is out. Then the next one is pheochromocytoma. Pheochromocytoma, usually it will present with paroxysms of hypertension. In between he will be having hypertension, then he will be relatively alright, maybe with very high BP, sweating and all those things. So these paroxysms, it is not at all mentioned. So it is unlikely to be pheochromocytoma. So the only choice left is renovascular hypertension. So in renovascular disease, especially in this patient who is 70-year-old, that is the answer, because urine is normal in a patient who is a 70-year-old patient who is having hypertension for a long time, which has recently become uncontrolled. So it is most likely to be renovascular disease. So the answer is renovascular disease.